Well, thanks very much, and thanks for the invitation. The point of the title really is to point out that, that Toxoplasma has a really exceptional host range in that it can infect basically any warm-blooded animal or bird. Now, we're not, and there's an enormous amount of work done on animal toxoplasmosis, which we're not going to discuss, of course, but concentrate rather on the human aspects of human infections. But of course, we can't help but mention animals along the way. So the organism was first isolated in 1908, and the name comes from toxon, which is a Greek for bow, and plasma, the form. So a bow-like or crescent-like form, and you can see it's very clear why it was called that. There's some tachyzoites escaped from a monocyte on the left there, scanning EM on the right, showing the crescent-shaped, shape. And gondii refers to the gundi, which is the animal in which the organism was discovered. At the same time, I mean, this is just a footnote, really, but it was simultaneously described in Brazilian rabbits by a Brazilian researcher, but he didn't name the organism. So the organism belongs to the phylum Apicomplexa, which is a collection of eukaryotic protozoa with many members. And many of them are not relevant to human disease. Some of these apicomplexan members you'll recognize. There's the Cryptosporidia. Can I get a pointer here? There we are. There's the Cryptosporidium. There's the hematozoa, which you'll remember malaria parasites, of course, and the pyroplasms. Babesia infects humans. And then we have the coccidia. And again, some of these you will recognize. There's Cystoisospora, as it's now called. And there's Toxoplasma and Sarcocystis, which sometimes also infects humans. So the taxonomic separation here is because Isospora and its relatives is what's called monozenic, which means it affects a single host, whereas Toxoplasma is a dizenic coccidian, and which means it's got two hosts. I think the other species we don't have to be concerned about. In summary, this is the life cycle. We have a definitive host, which is cats of various sizes, so felines more broadly. So domestic cats are the ones that are really important as far as human exposure is concerned, but tigers, cheetahs, lions, etc. Also act as definitive hosts. Because they are definitive hosts, they host the sexual stages of the parasite, which ultimately results in oocysts being passed in the feces. Now, initially, these are non-infective. They have to sporulate and produce the infective forms, and this takes a few days in the environment. So the oocysts are then the infective stage for a whole range of intermediate hosts. So that whole broad range of animals, many of which are wild and not of relevance to humans, but of course domestic animals are kept by humans, and then humans themselves act as intermediate hosts. So being infected by these oocysts. And then if an acute infection occurs in a pregnant woman, you can get transplacental transmission. And So that's the one route via oocysts. And then, of course, the other route of infection between intermediate hosts is the tissue stage of the parasite mainly in the muscles, because that's important tissue that is eaten generally, but also other tissues. And these are infective for or circulate via predation and carnivorism, in which humans, of course, actively participate. And these also form the infective stage for the definitive hosts. So what's happening here is unusual in that there are two overlapping life cycles. So amongst the feline population, we get the production via sexual reproduction of oocysts, which then infect intermediate hosts, and then there's another transmission cycle between intermediate hosts. And from the infective stage inside the oocyst, which is the sporozoite, we get acute infections produced by tachyzoite forms of the parasite, and then they come into equilibrium with the bradyzoites, which are the latent or the tissue stages, dormant or latent tissue stages. And at times these can activate and then start lytic cycles to produce tachyzoites. And transmission within this intermediate host populations can then take place by predation and carnivorism. Now, cats themselves can be infected by oocysts, but they more commonly probably acquire the infection from infected intermediate hosts. So don't worry about all the details here. This is just to show you the ultrastructure of tachyzoites on the left and bradyzoites on the right. So superficially, they're similar. And what this does show is the reason these parasites belong in the apicomplexan phylum, because all members contain this group of structures and organelles that form something called the apical complex. And this has evolved to allow the parasite to gain entry into cells and establish intracytoplasmic infections in host cells. And I think that there's a lot of information which we really haven't got, which is not necessary to go into now, but these organelles, the rhoptries and the micronemes, contain substances which allow the parasite to affect the outer membrane of the host cells, penetrate and get into the interior in a vacuole that originates in the outer membrane of the host cell. Now, ultrastructurally, the tachyzoites are slightly different from the bradyzoites in that the latter have increased amounts of a carbohydrate called amylopectin, and there are some other subtle morphological changes that we don't have to mention here. But obviously, metabolically, they are different in that the bradyzoites replicate slowly or become stationary in their form inside the latent tissue form of the of the infection. Whereas the tachyzoites, as you can tell from their names, are more rapidly replicating and produce cell damage through their replication. So they undertake lytic infection cycles, where if we start at 12 o'clock here, this is the process. So we have the tachyzoites coming into contact with a cell, attaching, orientating themselves, activating their apical complex, gaining entry to the cytoplasm inside this parasitophorous vacuole, replicating inside this vacuole, often producing these quite pretty rosette-like structures, emerging from those and exiting the cells, in the process lysing the cell, and that's why it's called the lytic cycle. And then immediately going on contact with other host cells, the whole process continues. So if we visualize this under the electron, with the help of the electron microscope, here we can see a tachyzoite in the process of activating its apical complex up here, producing this invagination of the host cell membrane, the so-called moving junction, which the parasite induces the host cell to roll its membrane around the outside of the tachyzoite. Eventually, you land up with the tachyzoite inside this parasitophorous vacuole, and immediately there are changes in the cytoplasm induced by this invasion. Mitochondria and ribosome and ER, endoplasmic reticulum, congregate around these. So the parasite really takes over some of the workings of the host cell. The parasite then divides by this process called endodiogeny, in which a mother, or the original parasite, produces two daughter parasites as a result of replication of the organelles inside that original parasite. So in other words, a mother tachyzoite eventually produces two daughter tachyzoites. It's really a form of binary fission, but a very unique one. That's what's happening there. Here you can see the nascent daughter tachyzoites forming inside the mother one, which eventually gives up all her structure to her daughters. And under the light microscope, that's what's the arrow is pointing that out over here. The arrowhead is pointing to the nucleus of the host cell. And here, the process has proceeded through several stages, resulting in, you can see a collection of tachyzoites, all sticking to one particular structure inside this cell, which eventually will rupture and release the tachyzoites, which is what you see happening there. And the end result is tissue damage, necrosis, central necrosis in a lesion, and active replication around the outside. Here you can see a lesion in, I think it's a mouse brain, some satellite lesions, which the arrows are pointing at, and then the arrowheads are cysts containing bradyzoites, which have already formed. At higher power, there's the central area of necrosis, and around the outside are actively, all the black dots are, I think this is an immunologically, some sort of immunocytochemical stain, actively replicating tachyzoids. Bradyzoite formation, there on the left-hand side, you can see bradyzoites, and morphologically these differ from the lytic infections of tachyzoids by being enclosed in a distinct membrane, which the tachyzoid lesions are not. And these show host cells in the process of producing the bradyzoites, which, as I mentioned, form the latent or dormant stage of the infection. Here's a well-developed cyst containing numerous bradyzoids, and it's demonstrating through the PAS stain, which stains carbohydrate moieties. These nice pink blobs are all the amylopectin accumulated in the bradyzoids. The arrowhead shows the distinct, fairly distinct cyst wall, which is not PAS positive, but you can still see it in this section. Here, scanning EM showing a ruptured bradyzoid a ruptured cyst releasing all its bradyzoids, a large collection escaping from this cyst. And this is a mouse brain H&E section showing a cyst at low power on the left and at high power on the right, packed with bradyzoids. Now these can persist. These cysts can persist for the remaining life of the host, and infection may remain completely dormant, asymptomatic, unless some immune compromise occurs. And in fact, you don't necessarily need to be immunocompromised to have a reactivation. That especially applies in eye infections, which can become dormant and then reactivate even in immunologically normal hosts at a later stage. But we'll say more about ocular toxoplasmosis later. So the infection of cats can take place by really three stages: the oocysts, which I've mentioned, tachyzoids from an active infection in an intermediate host which has been caught and eaten, or bradyzoids. Now the bradyzoids are most quick to produce the sexually reproducing stages, I should say, in the cat. And then we get release of the oocysts, immature at first, non-infective, once in the environment, sporogony, which means to produce the infective stage, the sporozoite, inside the oocysts. So the important points here are these have to be in the environment for a couple of days before they become infective. So practically that means if you have an infected cat using a litter box, if you dispose of the cat feces promptly and don't let it lie around for any length of time, you remove the danger of infection from that source. The second point is these cats produce enormous numbers of oocysts, up to 28, 30 million oocysts per day. So they produce highly infective feces, but production stops fairly promptly. Within 2 weeks, the production of oocysts stops. The cat is then immune and cannot become infected again. So practically, that means that it's really young, naive cats in terms of infection. So cats, for example, a kitten catching its first infected mouse will be infective in producing oocysts for a while, and then for the rest of its life, not be involved in transmission of the parasite. So worldwide, it's estimated that about 30% of the population, the world population, is seropositive, but this is highly variable depending on where you look and at whom you look. So some examples here are, and there are lots of these studies showing, different figures, but these are some that were quoted. Brazil in the 90%, UK 8%, USA 38%, Korea 4%, France currently probably around about 40%, much lower than it was previously, probably through public health efforts. In Africa, in immunocompetence, Ethiopia at 75%, South Africa around about 6%. In women of reproductive age, 83% in Madagascar, around about 13% in women, in South African women. This was our own study at NICD, so a relatively small sample, but one of only few that have been done locally. In HIV positives, again about 80% in Ethiopia, somewhat higher proportion in South Africa. So that's interesting, but really the important prevalence figures are the ones is the one of acute toxoplasmosis in pregnancy, because that leads to congenital toxoplasmosis. So overall, in a large meta-analysis, it was shown that about 1.1% globally, a 1% prevalence of acute toxoplasmosis in pregnancy. If you use more strict criteria, in other words, a proven infection in pregnancy, it's about half that figure, about 0.6%. Highest Eastern Mediterranean region, so this is the WHO Eastern Mediterranean region. In other words, North Africa, Middle East, lowest in the European region, but overall significantly high in countries with basically poorer, less developed countries, those with more tropical climates, which really that's what lower latitudes and longitudes mean. In other words, closer to the equator and really closer to the African latitudes. So this does agree with the estimated global incidence of congenital toxoplasmosis largely, which show that it's highest in the Middle East and some low-income African countries. And it's been estimated that there should be about 200,000 cases of congenital toxoplasmosis annually in the world. Now, if we look at that graphically, this is the presence of acute toxoplasma infection in pregnant women. And you'll see there are no published data from South Africa, in this meta-analysis at least. And it does seem to be not frequently recognized in South Africa. I mean, one can work out the expected incidence if one knows the background seroprevalence and the expected rate of congenital transmission. So just a word about a genotyping of the parasite. It's a single species, but quite a while ago, 3 genotypes were identified amongst isolates in Europe and the USA. And they were named 1, 2, and 3. And most congenital toxo there was caused by type 2 strains. But subsequently, multi-locus sequence typing and other genetic techniques have shown that other continents have more diversity, particularly South America. And this reflects probably a more increased transmission between contact between infected hosts. And one can find recombinant genotypes, so combinations between those classical genotypes, but also new haplotypes emerging, clonal haplotypes, and atypical genotypes. In Africa, haplotypes 1 to 3 have been described that coexist with type 2 and type 3 parasites. And although most infections by type 2 in Europe and USA are really mild in immunocompetent adults, these atypical strains, especially in South America, have been shown to be more severe, and cause severe or even fatal cases in immunocompetent. So there is some relationship between virulence and genotype. So from the clinical point of view, in immunocompetent people, symptomatic infection is uncommon. In pregnancy, 50% or slightly more are asymptomatic or only present as mild, non-specific flu-like illness, which may go disregarded or unnoticed. But where symptoms do occur, they present acute toxo presents as malaise, fatigue, headache, sweating, myalgia, arthralgia, fever, and there may be a rash. It's a fairly non-specific or very non-specific illness of limited duration, although sometimes malaise and fatigue may persist for months. Lymphadenopathy often accompanies symptomatic toxoplasmosis, generally around the head and neck. And sometimes you do get persistence of this of these lymph nodes and symptoms similar to what's can be produced by EBV and CMV as a mononucleosis syndrome. And in some cases, this and ordinary acute toxo may progress to more severe diseases, which includes myositis, myopericarditis, pneumonitis, etc. And retinochoroiditis is well recognized as a risk in postnatally acquired toxoplasmosis. So 4.4% of adults in a Brazilian waterborne outbreak presented with retinochoroiditis. This is not a very good picture of cervical lymphadenopathy in a boy with acquired toxoplasmosis. So what's interesting is that Toxoplasma infection has been linked to certain human behaviors, but it's really difficult to establish a firm cause-effect relationship. These are associations, but a causal link is difficult to to prove. And seropositivity has been linked to changes in reaction time, a tendency for accidents, behavior, even mental illness. But it's really difficult to say this is a cause, toxo is causing these. And this is somewhat different in in animals in that it's much easier to do experiments in animals. And you'll all know about the effect on mouse behavior produced by toxoplasmosis, in that infected mice become less scared of cats and therefore more likely to be predated, which is an obvious selection mechanism. They may also lose their distaste of cat urine. In fact, may even be attracted to cat urine, and of course that again puts them in a more susceptible, makes them more susceptible to predation. I think that's all I've got time to mention here, but just to say it's a contentious issue. There are other, I mean, Stephen mentioned link between toxo and rhesus factor that has been promoted by some researchers. Again, I think very difficult to prove that. Now, coming on to toxo in immunodeficient or immunosuppressed people, it's usually reactivation, it's thought, and certainly quite long ago it was shown that a CD4 of less than 50 was a risk factor, but you can also get it through transplantation, bone marrow, or transfusion of leukocytes, especially to seronegative recipients, and transplants from seropositive to seropositive donors to seronegative recipients. Seems to be more dangerous than from seronegative donors to seropositive recipients. I guess that's probably because they've already established some sort of equilibrium with their infections. And most malignancies are associated with toxo are hematological, particularly Hodgkin's disease, and is less commonly associated with solid tumors. And multiple organs can be infected, although widely disseminated disease is not that common. Toxoplasmic encephalitis, of course, is one of the classical presentations of HIV-related toxoplasmosis. And the lesions can be throughout the brain. This is a picture of a brain from a patient with treated Hodgkin's disease, showing necrosis in the basal ganglia here, and a typical ring-enhancing lesion on the scan. I'm sure you've got much better scans nowadays, and I've seen this. Moving on to ocular toxoplasmosis. So this is the most frequent cause of posterior uveitis in the USA and Europe. And in some places, a larger proportion of ocular toxo is acquired rather than a congenital. For example, in Brazil, which seems to have a larger problem with toxo in general. But 80 to 95% of systemic congenital toxoplasmosis cases have got ocular involvement, and a lower percentage of those without systemic infection. So clinically, you get the patient complains of visual impairment, and this is due to lesions on the retina itself, especially if the macula is involved, but also vitreous inflammation, which gives rise to the headlight and the fog symptom. Nerve involvement, optic nerve involvement is less common, but when it does occur, it can give rise to severe visual field defects and loss of color vision. Scotomas can occur, and you get a variety of other features, including retinal detachment. So these are a few pictures. This is a 63-year-old man, I think without any particular risk factors, but shows active chorioretinitis with local vitritis, which shows up as these white lesions in the vitreous. That's resolving. You can see the vitritis has subsided somewhat after 2 weeks on cotrimoxazole and prednisolone. And this is a recurrence. I must say I can't necessarily point out the details here, but apparently vitreoretinal adhesion and a new focus of active retinitis. Not sure why this is not advancing now. Gosh.
John, could you try the arrows maybe at the bottom left? Don't know if they work.
Oops. I think we'll wait for the program to respond if you don't mind. There we are. Okay, so here's another case. Again, an immunocompetent with a retinochoroiditis at presentation. There you can see the vitreous, the choroid showing through is this pale area, showing through the damaged retina. Here, same patient, active chorioretinitis next to the old scarred lesion. Well, again, I'm not sure which is which here, but that's very typical, this clustering of lesions, and here's a recurrence within 5 years. This area looks like this one on this previous picture, new lesions appearing there. So if we have time, I've got a few clinical cases, one of which is a case of recurrent retinitis. Let's see how we go, I think. We need to address, of course, the elephant in the room, which is congenital toxoplasmosis and transplacental transmission. And I'm sure a lot of this is well known to you. That it usually occurs through new infections in pregnancy or infections acquired just before pregnancy, and sometimes during reactivation, but that's pretty rare. The overall transmission is estimated at 24%. Risk is lower in the first trimester, up to 15%, and highest in the third trimester, but early infections tend to be more severe than late infections. So again, especially the pediatric people will know this very well. So most commonly it's inapparent at birth, just over 50%, although some of those will later develop retinochoroiditis as the most common late presentation of congenital toxoplasmosis. Can get severe effects on the pregnancy, but giving birth to a live infant with severe disease is relatively rare, only occurs in about 10% of cases. The classical triad is retinochoroiditis, intracranial calcification, and hydrocephalus or microcephalus. And in 10% of babies born with apparent toxoplasmosis, 10% will die within 4 years, will be dead within 4 years. There's a variety of ocular disease manifestations, and so that we're talking about presentation at birth here, but disease developing in the early months of life, although it may not be apparent initially, tends to be somewhat less severe, but can present as convulsions, nystagmus, a bulging fontanelle, and increasing skull circumference. So there's a baby with hydrocephalus, and the pathogenesis is that you get severe effects on the endothelial lining of the ventricles. You get blockage by cellular debris, and that gives rise to obstruction to CSF flow in hydrocephalus. Here's a baby with less overt hydrocephalus, but a bulging fontanelle. Here's a child with microphthalmia, and this is intracranial calcification picked up incidentally in a 10-year-old who was somewhat mentally retarded and had active chorioretinitis. So in terms of diagnosis of toxoplasmosis, so radiography and ultrasound of infected tissues or organs is suggestive, not diagnostic. Histology of biopsy tissue will give you evidence of histological evidence. The ultimate proof of infection is isolation in mice or tissue culture, but that's really done only in very specialized reference labs, not in this country as far as I'm aware. Likewise, a PCR is sensitive and specific. In terms of diagnosis of ocular toxo, the fundoscopic appearance is often diagnostic. There's very little else looks like that. And there are some specialized ophthalmological techniques which can be used to look at the stage and progress of the disease in the eye. So probably the most commonly used diagnostic method is serology, and there are various techniques. The original one is Sabin-Feltman dye test, but not really done routinely other than in reference labs. And ELISA is the most common method used in routine laboratories. And in areas where toxo is common, this may need to be complemented with the various other diagnostic techniques. But basically, this is a special treat for the Swedish speakers, but basically it shows the pattern of immunoglobulin production, and it's really a typical of many infections. IgM, IgG, IgA. You can also, some people claim IgE is helpful. This shows the increase in IgG avidity, which is an important aspect of assessing the stage of disease or stage of infection particularly in pregnant, a suspected infection in pregnancy. So diagnosis in pregnancy can be complex. This is one of the more simple flow diagrams. I haven't got time to go through it. I didn't plan to either, but just to point out that it can become much more complicated with connections going all over the place. Just looking at some of these are French guidelines, and they've got a special interest in toxoplasmosis. Some of these diagrams are really complicated, and just looking at a few of them in detail, I noticed some errors, arrows pointing the wrong way and missing connections and so on. So it's not that simple. But for the odd inquiry that comes our way, I found this to be a very useful reference. It's quite old now, but it gives very clear guidance as to the likelihood of infection in various scenarios, and it ranks them as definite, probable, possible, unlikely, not infected, according to the laboratory, mainly serology, but also other methods are taken into account. So I found that really a useful guideline, because one does want to give the right advice, especially with suspected infections in pregnancy. So just very quickly, if I'm allowed to, Jeremy, or do you want to leave? Do you want me to stop then, leave some time for discussion?
No, why don't you go ahead, say another 5 minutes or so, and then we can take some questions afterwards.
Okay. So we get really relatively few cases of or consultations about Toxoplasmosis, and we can speculate why it's maybe less than we should. But anyway, this was a 29-year-old who was trying to get pregnant. This was in January 2016, and Toxoplasma serology was done, which showed positive IgM and positive IgG. So what would people, or what would someone suggest would be the next step? I'll wait a few seconds and then give you the answer.
I was going to say, if anyone wants to just type in the chat or type in the Q&A, but I'll have a look at it. So your question is, what would you do next? Any thoughts from the audience? I would be quite keen on looking at avidity, John. Do we have that yet?
I think the first thing is to just repeat the serology and make sure it's. So obviously the issue is, does this represent an acute infection? So one way is to repeat it in a few weeks and see if the IgG has gone up. And it hasn't. It basically stayed the same. So the next step, as you say, Jeremy, is avidity. And that is exactly what was done. I presume she hadn't become pregnant in the meantime, because they don't seem to have been that anxious or urgent about it. But avidity was done, and this showed a reading of, or an index of 101%, which is high avidity. In other words, a very mature immune response, which means the infection had been, it was an old infection, basically. The reason for the IgM still being relatively well detectable is not that surprising. IgM in toxo can persist and can reappear for quite a long time after infection. So she had had acute toxo in the past, and in fact, going back in the history and the lab results, these showed that in 2007, when she was then 20, she had had an axillary lymph node biopsy, presumably presented with lymph adenopathy, and the histology reported a reactive lymphadenitis that supported Toxoplasma, although it's not completely specific, but they suggested that she be checked for HIV as well, which was presumably done. And at the time, serology was also done, which showed evidence of acute infection. So it confirmed the histology results on the biopsy with high levels of IgM and IgG. So that was relatively easy to sort out. So this was a case, another case, a somewhat older a woman with a twin pregnancy, and congenital infections were queried when ultrasound showed small pericardial effusions in both twins, and a congenital infection screening was done. The other suspects were all negative, but toxoserology showed a IgM high positive. So again, what should we do at this point? Let me show you. In the interest of time, let's show you. So this was the serology results at the first result. So a high IgM level on ELISA, but negative IgG. So this would be highly suspicious of an acute infection, and one would want to confirm it by repeating the IgG and looking for seroconversion. So that was duly done, and IgG stayed negative. So there's no IgG seroconversion, which basically rules out, certainly within this time span, acute infection. The reason for such a high positive IgM, again, is unclear. The sort of standard results from the standard report from the lab suggested this was probably a false positive. And what happened in the end, the mother did need to get a Caesar because of eclampsia, but the babies were well, did well, and all was fine. So isolated high IgM without IgG seroconversion does not equal the risk of congenital toxoplasmosis. So I think time is up. I've got one more short case, Jeremy. Again, you must say.
Yeah, sure. Go for it. Yeah.
This is a case of recurrent ocular toxoplasmosis. So the patient was had a selective IgA deficiency and was diagnosed with recurrent toxoplasmosis, had been treated with with cotrimoxazole, and apparently did well. And 10 years later, there was a recurrence, which is not uncommon with ocular disease. Again treated, this time clindamycin was added, and a long-term treatment or prophylaxis was suggested. This was stopped after 7 months, and then a few months later, there was another recurrence. Again, high-dose cotri was started, it seemed to progress, the disease seemed to progress, and azithromycin and clindamycin was added. So the questions were, and then pyrimethamine and folinic acid was considered. So the questions from the ID doctor were, are you aware of toxoplasmosis resistance developing to cotrimoxazole? Well, in fact, I'm not aware of any reports of resistance, but recurrent disease, despite previous treatment, is not uncommon. It's due to the fact that the bradyzoite cysts are not susceptible, because they're not replicating. they're not susceptible to antibiotics. So they just, the levels go down, and eventually for whatever reason, the infection reactivates. The correct dose, well, that was quite easy to look up. How long would you treat this gentleman who was HIV negative but had a selective IgA deficiency? Now, I haven't come across that as a particular risk factor for toxo, but I'm not, I'm not an expert on immunoglobulin deficiencies. And then the final question was, would you use combination treatment with Clinda, Azith, and Cotri? Well, again, there was I couldn't find any reports of that combination, but other combinations have been suggested. I think the important drug to add here is pyrimethamine, either with Clinda or azithromycin. You can even, there's even clarithromycin has been suggested. And then you went back on to, so pyrimethamine, the reason for pyrimethamine plus sulfamethoxazole is the classical treatment for Toxoplasma, but we don't have a sulfamethoxazole here. Hence the suggestion to add azithromycin or clindamycin. And then he did seem to respond to that and was put back on cotrimoxazole. So I'm afraid we haven't really got time to talk about the ins and outs of treatment, but especially in congenital toxo, that's quite a complicated subject. So I've steered well clear of that. But just to say, we don't have access to, the recommended drugs, spiromycin and sulfamethoxazole. Or do I mean sulfamethoxazole? One of the sulfurs, anyway. So I think that's it. Sorry to run over time.
Great, thank you so much, John. That's enormously helpful, and as usual, a lot of great information there. I'm just going to abuse you for a couple more minutes just to run through some of the questions that have come up, if you don't mind.
Sure.
We can keep it fairly quick, but it's important. Some really good questions. So 2 people have asked about the molecular assays for toxo. In other words, what are available currently in-house or commercial, and on what specimen types? And specifically, I think another person asked about Toxoplasma PCR and the CSF in the setting of the HIV positive patient with a CNS lesion.
Yes. So, well, firstly, the first question is, we are at NICD offering a Toxoplasma PCR on any sample you care to send us. The actual utility of it in toxoplasmic encephalitis, I think, is not clear. Obviously, if you get a positive, it's very suggestive, but a negative, I would guess, does not rule it out. But we're happy to offer the assay, and it has been, we've validated it, and it's now established as we can offer it routinely. We've had relatively few referrals, but it's available if anyone is interested.
Great. Thanks. And then there's a question about if you had a patient who you weren't sure about the serological interpretation during pregnancy, what time frame would you leave before repeating the serology? So when would it be useful to repeat again?
So I think the major concern would be, obviously you want to pick up acute infection. And the major concern would be if you have a positive IgM and a negative IgG, then you should wait a week and repeat IgG. If it's still negative, wait another week, repeat IgG. If it's still negative, well, by then you should have got an IgG response. And as in that case I mentioned, if they never seroconvert, then it's highly unlikely to be acute toxoplasmosis. And so the interpretation, as I mentioned, that reference is really very useful in looking at all the options. I find, in fact, much more useful than the flow diagrams, because it really gives you pretty helpful information. Obviously, if you find IgM and IgG, avidity is very helpful. Low avidity IgG would suggest a more acute infection.
Great, and thanks. Just what? Oh, sorry.
Yeah. No, that's it.
Okay, and just one final question was about the kind of with these cerebral abscesses that occur in HIV patients with advanced disease. They seem to resolve really quickly. And a question from one of the audience members was, are they true abscesses? And do you have any explanation for how quickly they resolve? Because often the repeat CT brains are virtually normal as opposed to, say, TB or even bacterial abscesses.
Well, there is active tissue damage. I think maybe abscess isn't quite the right term. They collection of foci of necrosis and inflammation, but obviously with the capacity to recover to some extent. I think the degree of recovery, I guess, depends on the extent of the lesions, and the degree of residual cerebral damage, I guess, also depends on how large the lesion is and where it is. But you would know more about that than me.
No, but yeah, thanks. It is one of the things we can actually sometimes use diagnostically between TB and toxoplasmosis in the face of a positive toxoplasma serology, for IgG, is that
Yes.
On treatment they tend to get better much quicker than tuberculomas in the head. For
can I ask? Yeah. Can I ask you a question? Do you rely on cotrimoxazole primarily for cerebral treating putative cerebral toxo, or do you add anything else or use anything else?
No, I mean, we don't have, it's sulfadiazine is the other drug, and it's not available in the country. So we've used Bactrim in the HIV epidemic more or less entirely. And there's some pretty good evidence, I think, some moderate quality evidence that they are equivalent. But in any case, it's the only thing we have. So we don't have a lot, but as Dave was saying, it works. We see really good results. I mean, if you get them over the first few days of a bad intracerebral lesion and control the edema, they all resolve. We basically don't see treatment failures in confirmed toxo. Obviously, sometimes it's very hard to know what the lesion is without a biopsy. But yeah, we've anecdotally had very good results. But I think most countries around the world treat it with just Bactrim, I think, because of the availability of the other drugs.
Yeah, if you look at the SAMF, it does give some other options for treatment and prophylaxis, some of which do involve pyrimethamine, not forgetting to add folinic acid if necessary, or routinely, I guess. I don't know if that's available in the public sector. Pyrimethamine I'm talking about.
Stand to be corrected. I don't think so. It may be available. I think it's in the country. You can get it as a buyout or something, but I don't think it's on the EML list. But it could be done, as you say, with leucovorin and clindamycin as well.
Yeah.
Yeah, it's certainly possible. But I think most people are quite happy with the Bactrim, and it's much more convenient to give as well. It's got very good bioavailability and adequate CNS penetration that seems to respond well. I mean, the chief problem is really making the diagnosis without a brain biopsy, which is challenging because we end up with toxoplasma serology that's positive. But as you say, that in terms of IgG, but that alone is not conclusive because you could have had past toxoplasmosis and a current tuberculoma, in which case, you know, you're quite stuck. So we often end up treating for more than one thing. But you know, where it has been confirmed, they do seem to respond pretty nicely. Oh, and sorry, we've got one of the audience members, Graham Mankeys, has just said that pyrimethamine is section 21, he thinks.
Oh, okay.
So presumably could be done that way, yeah. Yeah, all right, well, thanks. I have to unfortunately call a close to this point, so we've gone over a bit, but thank you so much, John, for your time. It's really incredible to hear from you always, and you teach us so much. So thank you for your time and patience, and taking time out of the special pathogens course as well. You've been going from lecture to lecture today, so thank you, much appreciated.
It's a pleasure. Thanks for asking me, and apologies for running over. You know, we still didn't cover really everything about toxa, but anyway.
No, it's a huge topic and a complicated bug, but we'll get you back to have another crack at it as well. But thank you so much, hugely appreciate it.
Okay, great pleasure.